Thank you very much for that introduction. I wanted to share with you a little bit, to start a little bit from where I come from, what I do, and how I think a little bit about sleep. So so I'm a behavioral sleep medicine specialist. And what is a behavioral sleep medicine specialist? And what is BSM? So it's a field that is focused on evaluating and treating sleep disorders and addressing factors that interfere with sleep. Now, everybody sleeps. Not everybody has a sleep disorder, but what we know is that there is a great deal of maintaining a behavioral pattern or addressing behavioral components to achieving healthy sleep. And this is across the board. So BSM is this area of medicine, behavioral medicine, and science that really looks at the behavioral and psychological component of improving sleep. Now, when you're thinking about BSM interventions, the most famous one is cognitive behavioral therapy for insomnia. There's a lot of CPAP adherence for sleep apnea, managing and dealing with the concerns of the PAP device, and chronotherapy. Chronotherapy is to manage jet lag, to manage circadian rhythm disorders, and situations that occur with impacts to the circadian rhythms, that are core biological rhythms. Now, there is a Society for Behavioral Sleep Medicine, the SBSM, and its mission is really to promote and to provide standards for behavioral sleep medicine, healthcare, education, and research. Now, if you'll notice, the examples of BSM intervention here do not include hypersomnia or narcolepsy. And this is something that a while ago, when I was in Rush University Medical Center doing my residency, I got introduced to Dr. Jason Ung. And together, we really started asking, hey, what is going on with narcolepsy? What are the behavioral and non-pharmacological management approaches for narcolepsy? This was a very interesting and challenging task that Dr. Ung provided to me, because it was not a lot there. I was trying to look at the research, and I'll show you some information, what we found, and really summarized into one table. As you can see over here on the left, we can see that there were a few studies that looked at non-pharmacological treatments for narcolepsy. And all of these evaluated excessive daytime sleepiness, either objective or subjective ways. You can see some of the studies focused on evaluating how naps do, okay? Some of them evaluated diet approaches, and there was some other components. But there was no really overwhelming data on different approaches. When you think about what they evaluated sleep attacks, cataplexy, hallucinations, sleep paralysis, nocturnal sleep, and performance. Some of them, everybody did excessive daytime sleepiness. However, when you're looking at psychiatric symptoms, only one study considered that as an outcome. That was a little bit concerning to us. What we also found is that there were no quality of life outcome measures. So we wanted to do a review of cognitive treatments. What are maybe not behavioral components? What are some cognitive treatments for narcolepsy? And well, we found none. And that was really concerning. So what we did is we wanted to go and really try to understand what are the needs of individuals with narcolepsy and hypersomnia disorders. And we did a survey, which we really wanted to access as many narcolepsy participants and individuals with hypersomnia And what we were able to get is 371 individuals. We got it through Wake Up Narcolepsy and through the Narcolepsy Network. We sent out emails, and this was nearly 10 years ago now. And what we found is that from this sample, more than half were narcolepsy, and the majority were female. They were about 37 years old, and they had the symptoms for nearly 2 decades. So I want to show you something really interesting. This blew my mind. Sad mood was reported by 80%, okay? Loss of interest, and we're talking about in the last month, loss of interest, 80%. Irritability, 86%. Concentration difficulties, 91%. So there's a huge, huge amount of reported deficits that are associated with these disorders. So what are the behavioral strategies that people are using? I mean, if you think about it, maybe the doctors don't know what to do, but individuals with narcolepsy and idiopathic hypersomnia, they and you really try to deal with it day on, day out, right? So what do you really do to manage this? So we asked this question. And what we found is that daytime naps is used nearly by 85%. Scheduled sleep time is, 3/4 of the sample. We're using scheduled sleep times. Caffeine as a way to manage wakefulness was used by 75%. Exercise by about half, and diet by about half. And mindfulness and yoga were about 20%. So the question was, how did you learn about these strategies? Trial and error, 78%. I figured it out on my own. Internet, 44%. Other patients, 38%. Sleep specialist, only 1/3. And physician, their own primary physician, by 1/4, and that's it. So really a lack of ability to provide cohesive and structured approaches, non-pharmacological approaches to the management of excessive daytime sleepiness. We also asked, what is your interest in cognitive behavioral therapy for hypersomnia? 40% said, yeah, absolutely interested, okay? And if you consider it, about 70% said, yeah, they would be somewhat interested in higher. How much of you are interested in yoga and mindfulness? Again, 70% had more than somewhat interest in these non-pharmacological approaches as they're directed specifically to narcolepsy and hypersomnia. And how many are interested in support groups? And that's more than half. Easily said, extremely interested, extremely needed also. Look, I won't be belaboring the point over here, but the humanistic and economic burden of narcolepsy and idiopathic hypersomnia are staggering. I wanted to show to you one component over here. This is a comparison of psychiatric illness between individuals with narcolepsy compared to controls, people without narcolepsy. And what I want to see that people with narcolepsy are 33% more likely to have depression, 25% more likely to have anxiety disorder, and are 32% more likely to have any anxiety disorder, okay? And however, if you think about all of these were higher, significantly higher. All of these psychiatric illnesses were higher in this patient population, in this sample. So the impact on quality of life is major, and you see it in difficulties in school, work, relationships, leisure activity, and at least half of the patients with narcolepsy report at least mild symptoms of depression. And about 15% actually meet diagnostic criteria. we know that there's a significant reduction in quality of life over 5 years for patients with narcolepsy. So this is obviously very, very concerning data. One of the findings that I thought is very, very important is that the reason for this impact is a result of perceived stigma. And there was a study that was done very elegantly and looked at the effect of daytime sleepiness on functioning. And they found that significant amount of daytime sleepiness results in perceived stigma, not only by the environment, but also self, and expecting, oh, I'll be stigmatized if I go out. I will be, if people will see me in this way or understand me, I will be ridiculed. And that perceived stigma resulted in direct impact on depression and resulted in decreased functioning. All of these are very, very, very important. And there's a great deal of interpersonal deficits. 72% with people with narcolepsy report issues with family and marital problems. And in children, issues within the family, peers are very complicated, and bullying is a big issue also. And this could lead to severe social impairment and social phobia, as well as psychiatric disorder. So the need is there, the desire is there. What do we have, right? And really, it seems like we're at the end of the road. It's needed, it's wanted. Can we do it? It's not there. We don't have a cohesive, non-pharmacological approach to managing narcolepsy. So what do we have right now for the treatment of narcolepsy? So I took a look at the practice parameters for the treatment of narcolepsy and other hypersomnias of central origin. That's the major sleep outline of how do we, a sleep professional outline, how do we actually manage narcolepsy? And the result, actually the first thing that they say is excessive daytime sleepiness has a significant detrimental impact on psychosocial and psychological and vocational functioning and personal safety. And they go on in the entire rest of this document to talk about drugs. And I'm not going to talk about the drugs, you know them. Other talks have been focusing on them. There was one small excerpt in this long document that talked a lot about drugs that said the following: scheduled naps can be beneficial to combat sleepiness, but seldom suffice the primary therapy of narcolepsy. Okay, and there was a recommendation to do 2 15-minute regularly scheduled naps. So what's missing over here? And really, what's missing is looking at the value of health. Look, I'm not probably not going to be able to ameliorate narcolepsy. It's not my area of specialty. The question is, how do we manage health within the area of narcolepsy? So when I think about a value, I think about the direction. For instance, going west. You can never actually reach west, right? But you can always go and strive towards west. So it's an ever-striving effort. And it's very different from a goal. A goal is like, you can check it off. I can, to be healthy is a value. I will always need to work on to improve my health. But losing 5 pounds, that is a goal. I can check that off, okay? The thing is that we have a long route towards health. It will take us a while to get there. Possibly we'll never get there, right? Because it's a value. On the way, we have these goals that are reachable. So taking this approach, Dr. Ung, which I mentioned in the beginning, started developing with his team a cognitive behavioral therapy for hypersomnia. And it was a feasibility trial, and it went out very well, and they're continuing this work. And this approach is not necessarily focused on ameliorating excessive daytime sleepiness. Actually, quite opposite. It's more focused on managing and more focused on managing the impact that narcolepsy has on your life. You know, very common, we hear comments of stigma and impact, social impact of what narcolepsy does. A lot of my patients represented here in this excerpt give a really stark feeling about always being sleepy. I'm tired of always being tired is a very common state to hear from patients with narcolepsy. And what these treatments, these non-pharmacological approach, is really focusing on how can we focus on our emotion? How can we better manage our emotional paradigms? Dealing with avoidance behaviors, not going places because of our symptoms, and being very problem focused, being able to manage the situation at hand. So I wanted to give you a little bit of a different approach than what Dr. Ung is looking, and stuff that I am doing right now. And we tend to look at health as through the 3 pillars of health. Sleep is one of them, but there's also exercise and nutrition, okay? Now, the combination of all of 3 of them has been shown from the Old Testament. The sleep of a laborer is sweet, whether they eat little or much. But as for the rich, their abundance permits them no sleep, right? So there is a relationship between fitness, diet, and sleep. And one of the core ways is through circadian rhythms. Look, when we go about our day looks in a certain way, even with narcolepsy, okay? Though it's much more difficult. In a normal situation, in a non-narcoleptic environment, sleep onset would be in a certain time, let's say 11 over here. You'll have your deepest sleep at 2 a.m. And REM sleep more so at 4:30, again, non-narcolepsy, right? Melatonin will stop in the morning with the first light. You'll most likely have a bowel movement. This is also true for individuals with narcolepsy. You'll have high alertness. The highest alertness is usually achieved just before noon. And then there is different cognitive components that and physiological components that are time dependent. Melatonin eventually starts secretion about 8 p.m. and the normal person would be able to then suppress their bowel movement and then go into sleep time. This looks very, very different when you have narcolepsy. So we need to think about a little bit about circadian rhythms. What are circadian rhythms and how can we improve them? So circadian rhythms are core biological oscillating components like systolic blood pressure. It has a circadian rhythm. Insulin has a circadian rhythm. Leptin, these are food hormones that are regulating your satiety and hunger. Melatonin is a very famous circadian rhythm biomarker. Core body temperature has a circadian rhythm. Even mood, alertness, and memory have a circadian rhythm. So this is interesting because circa means about and dien means day, about a day, but it's not a full day. It's about 24 hours. And it's interesting because as you can see in a normal situation, it's a little bit complicated over here. A person goes to sleep approximately the same time and wakes up at the same time. But then if we put you in put them in a cave, devoid of any external stimuli, they will start getting a little bit delayed. What does that mean? They will go to sleep a little bit later. Why? Because the circadian rhythm is about 24 hours. It's actually longer than 24 hours. And if we didn't have a way to keep our circadian rhythm at a 20 hours, like if you're in a cave, you will end up going to sleep a little bit later every day. But then when we give you those cues, you can then go back and really stabilize your sleep back to the 24-hour pattern. Now, why is that important? Because circadian entrainment, that's how it's called, is mainly done via bright light. We get bright light through our retina. It registers in the suprachiasmatic nucleus, which is our main area in the brain, which is responsible for these circadian rhythms. And then that provides all the information to the rest of the brain. However, it's not only by light. It is the strongest, we call it Zeitgeber or time giver, time cue in German. There's also other things that can improve the circadian rhythm, and that's activity, food, diet, and temperature. Together, if you take all of these together, they start signaling for all of your peripheral body and peripheral clocks in all of your organs and help regulate the functioning of these of your entire body. Interestingly enough, cancer in any given one of these systems is associated with circadian rhythm dysfunction that is seen in these peripheral clocks we can evaluate them through genetic expression. So I want to, so why is this important? I want to show you a few things. So this is data from individuals, young individuals, some who are reporting severe sleepiness, and two of them are healthy individuals. We don't know if they have narcolepsy. They were not evaluated specifically for narcolepsy, but they do report significant sleepiness during the day. And I wanted to show you a little bit how they look differently. So this is longitudinal actigraphy. So they used a watch that collects data on movement, and we can say, oh, is this person awake or asleep, or how much exercise or how much activity did they have, and when did they have very, very little activity. And if we look, this is a week of 7 to 14 days. This is of an 11-year-old boy. And what we can see is he had a high activity. This is 2 weeks of data, 7 to 14 days, but it's aggregated into a single 24 hours. So what you can see is high activity over here, and this is time. By midday, high activity. There's an activity peak just before there starts to be a gradual decrease in activity rate until the night. The nighttime is, and the sleep time is denoted here by the blue area. You can see they sleep fairly good through the night. Then they wake up and they go and they increase their activity to a certain amount. This is a 11-year-old girl, also healthy, no reports of difficulties with sleep or wakefulness during the day. Again, high activity rates during the afternoon, decrease sleeping relatively good during the night, and then increasing in activity, fairly rapidly increasing. Now I want you to show you some kids that did not reported some severe sleepiness. What you see is that there's this dip, really bad dip here in the middle of the day, possibly a long nap, right? The activity peak is significantly earlier before the nighttime starts. And there's this gradual time until the blue area over here for the nighttime sleep. And look, the nighttime sleep, it's not as regular and flatline, relatively flatline over here, but you see it just dips, guts here and increases. It looks very, very different. This is a 17-year-old boy. This is a 15-year-old girl, and we see a very similar, this dip, this significant dip. This girl also had much less activity compared to these two participants. And what we can see is that the activity pattern that we hold or our experience, our symptom experience during the day has reproduced in a graphic approach. And you can actually see the dysfunction that is experienced with daytime sleepiness. It doesn't happen only during the day. It also happens at night. And this is what we need to remember. A sleep disorder is not necessarily a disorder that happens at night only. That's sometimes a very common misconception. One thing that can override sleep is the stress response. I always try to tell people, imagine that you are sleep deprived for days, and then I tell you to get into bed, and you get into bed, you're so happy to see your bed, and you get into bed, just before you get into bed, I say, hey, I put in a rattlesnake in your bed. would you be able to fall asleep? And the answer is absolutely not, because the stress response is supposed to overtake it. Now, if we are experiencing a lot of stress and the stress response, the sympathetic activation, our body is in a fight or flight all day long. If it's perceived bias, or if it's just the difficulties dealing with our symptoms day in, day out, depression and anxiety, that will interfere with processes that are related to our sleep. So we need to think about, hey, how do I manage the treatment of narcolepsy, and how do I manage my strategies, and how can I do these together? The truth is that we don't really know. We didn't do enough studies to really look at it. But what we do know is, from very preliminary findings, that there's a great deal of daytime management that needs to happen. And you need to set yourself for success throughout. You need to be mindful about how you go about your day, knowing how to manage your non-pharmacological interventions as well as your pharmacological intervention. You know, when we talk about non-pharmacological intervention, we can talk about, yes, the normal sleep hygiene, but consider also the sleep environment. Where am I going to take the nap, right? If I'm going to take the nap on the Japanese street, I'm probably not going to wake up, or not going to be as refreshed. I'm going to have other issues, maybe some emotional concerns, right? Our sleep environment is important. Also, how do we structure our sleep environment? This is the most common error that I see. A lot of people, the first thing that they do is they look at the clock. What happens in that moment? You just moved your brain from a transitional sleep to a full-blown awakening. Now, that also puts a pressure on you. I woke up in the middle of the night, maybe to take another administration of my Xyrem. Maybe it's just because I had a arousal. Maybe because my overall sleep during the day increased the amount of time unusual, and therefore I had deficit in the middle of the night. Just looking at your clock decreases your ability of falling back asleep. So we started looking back in Rush. How do we help individual bring awareness? We started using daytime diaries. In insomnia, we tend to use nighttime. Hey, how did you manage your night? But in narcolepsy, what we found is that the daytime components are very, very important, and that they need to happen on a relatively regular pattern and to achieve a regular balance. I want you to consider if you thought back to those graphs that I showed you, of the sleepy children versus the non-sleepy children. Is one thing that was very interesting is how fast they woke up in the morning, and what did they do in the morning when they woke up. What you see is that individuals with sleepiness, they just dragged their feet. They did not become very functional or active quick. The question is, can I produce that with scheduling? And that's something that remains to be tested. And yes, there is tons more, there is tons of more work to do. And this is work in progress. As a society and as a member in that society, this is very, very important for us. And we are doing a great deal of push right now in the last few years to consider what is our response for the non-pharmacological approaches to better manage narcolepsy. Again, I'm not going to ameliorate narcolepsy, never. But maybe we can better serve narcolepsy or patients with narcolepsy and help with better management of their day-to-day experience using evidence-based approaches. Interdisciplinary management of narcolepsy has become a value. It may be not something we will ever be able to reach fully because it will be ever changing, but it's for now our direction in which we hope to achieve these goals on the way. So right now we're starting with small studies, feasibility studies, looking at just the measurement component, and Wake Up Narcolepsy has shown interest in and supporting research that is looking at these non-pharmacological approaches to the management of narcolepsy. So there's a lot of work to do. And what is to achieve the optimal interdisciplinary management? And in an interdisciplinary management, you'll have a sleep physician's role, right? You need to get a diagnosis. You'll do your polysomnography with your multiple sleep latency test. You'll get some pharmacological treatment. You will choose. You will work through it. You will make your best informed decision, and you will get ever so reevaluated and overall management by this physician. But there's also a role for a BSM provider, behavioral sleep medicine, and they, in the future, hopefully will have evidence-based approaches to provide regulation of the sleep-wake pattern, help with emotional regulation and coping with chronic sleepiness, and there's adherence to medication, because that's also important in the process of managing narcolepsy. At this point, it's a short talk. I'm interested in your questions and to best try and answer them. But for now, thank you very, very much for giving me this opportunity. And thank you very much for being interested in better ways and improvement of the approaches that we can focus and improve the life of individuals with narcolepsy. So thank you very, very much.